Welcome to The Explainer. Today, we're diving into an operating room where the most critical decisions, they're made long before the surgeon even picks up a scalpel. This is thoracic anesthesia, and it turns out one ancient principle can be the difference between success and sudden disaster.
So, don't burn your bridges. It sounds like something your grandpa might say, right? But for anesthesiologists managing these incredibly complex chest surgeries, this isn't just some historical wisdom. It is the golden rule. It's absolutely non-negotiable.
What it really means is you have to always have an out. Always. Because in these specific cases, a full-blown crisis can pop up out of nowhere with zero warning. You just can't afford to make a move that you can't take back. So, let's see exactly how this works in our first scenario.
All right, first up, we're talking about patients with what are called mediastinal masses. Basically, these are tumors right in the center of the chest, and they can be sitting right on top of the windpipe or major blood vessels. And get this, the simple act of putting a patient to sleep can trigger a total catastrophic collapse.
So how do you even begin to prepare for that? Well, the very first bridge to safety is just listening. Seriously. The symptoms you see here, they're not just notes for a medical chart. They are screaming red flags. If a patient says they can't breathe when they lie flat, that's a huge clue the mass is already squishing their airway. Feeling faint? That could mean major blood vessels are being squeezed shut. You absolutely have to catch these things.
And look at this protocol. You can see how every single step is built around that bridge idea. You keep the patient breathing on their own. Why? Because if you paralyze them, their own muscle tone disappears, and the airway could just pancake shut around the mass. It's that serious. And that rigid bronchoscope on standby? That's not just in case. It's the emergency bridge, ready to go, to create a new airway if the old one suddenly closes up shop.
Okay, let's switch gears. We're going to talk about a procedure where the biggest danger is totally hidden from the anesthesiologist. It's called a mediastinoscopy. This is where a surgeon uses a scope to get biopsies from lymph nodes deep inside the chest.
Now, one thing we're always watching for is the scope pressing on the innominate artery. That's a big deal because it cuts off blood flow to the right arm and even part of the brain. It's why we're constantly checking the pulse in the patient's right arm. But as bad as that sounds, believe it or not, something way worse can happen. Massive hemorrhage. I'm talking about a sudden, catastrophic bleed from a major vessel, deep in the chest where nobody can see it. The only sign you might get is the blood pressure just falling off a cliff. It's a signal of what we call hemodynamic collapse. The whole circulatory system is failing, and it just can't get blood to where it needs to go anymore.
And this is a perfect example of not burning your bridges. Look at step 3. Secure large-bore IV access in the legs. Why the legs? Seems weird, right? Well, think about it. If the big vein draining the whole upper body, the superior vena cava, gets torn, any fluids or life-saving drugs you push into the arms, they're just going to spill right out into the chest. They'll never even get to the heart. So, those IV lines in the legs? That's the backup plan. That's the bridge to safety you built before the disaster ever happened.
All right, now for a really unique challenge. Imagine you have the surgeon and the anesthesiologist trying to work in the exact same space at the exact same time. We're talking about a rigid bronchoscopy, which is often used to clear out blockages or place stents in the airway.
It's this constant dance, right? Do you let the patient breathe on their own? That's generally safer in terms of pressure on the lungs, but it can be a little unstable. Or do you use something called jet ventilation? That gives the surgeon a perfectly still, clear view to work, but it's a completely different kind of anesthesia and has its own set of risks. The team has to pick the right bridge, the right strategy for that one specific patient.
Now, just to make things interesting, let's throw a laser in there. Suddenly, you have a perfect fire triangle. You've got an oxygen-rich airway as the oxidizer, the laser as the spark, and the plastic breathing tube itself can become the fuel. An airway fire is an absolute nightmare. So keeping that oxygen level below 30%, that's not a suggestion. It is a non-negotiable bridge to making sure that nightmare never happens.
Okay, let's wrap up with some of the biggest challenges in thoracic surgery: major airway and organ reconstructions. This is where things get incredibly complex, and it all leads up to the ultimate pulmonary reset button, a full lung transplant. You know, every single one of these surgeries has its own unique puzzle. Take a tracheal resection. The surgeon literally cuts the windpipe in half. The anesthesiologist has to figure out how to get air to the patient, sometimes by passing a tube right across the open surgical field. It's like building a temporary bridge for air. Or for patients with myasthenia gravis, the bridge is about what you don't do. You avoid muscle relaxants completely because they could cause this really profound, long-lasting weakness.
But really, the ultimate test is the lung transplant. It is a perfectly choreographed sequence of incredibly high-stakes moments. First, the team has to safely take out the old, diseased lung while the patient is surviving on just one. Then, they have to meticulously connect the new organ. But that final phase, reperfusion, that is the moment of truth. When blood starts flowing into that brand new lung, there's a huge risk of this massive inflammatory reaction that can just flood it. The team has to see that coming and manage it perfectly for the whole thing to be a success.
So, okay, we've walked through some incredibly demanding situations, right? From a collapsing airway to a massive hemorrhage to getting a brand new lung. What's the one big thing we should take away from all this?
It all comes right back to where we started. In this world of high-stakes thoracic anesthesia, the core idea isn't just reacting to problems when they happen. It's about seeing every possible thing that could go wrong and building your bridges, your escape routes, your paths to safety before you even begin.
And you know what? This idea goes way beyond medicine. In any complex, high-stakes situation, the real key to success is anticipating the unexpected. It's making sure that you have never, ever burned your path back to safety.